Welcome for our discussion on COVID-19's impact on public health. There's no one I'd rather be talking to about this topic than Carolyn McClanahan. Carolyn is a financial planner and a medical doctor and has written extensively on epidemiology and public health, including talking about the coronavirus back in 2013 and making the point to all of us that we needed to pay attention to it as a potential black swan. Of course, that ended up being slightly relevant. She's here for the next hour. Great to see you, Carolyn. And why don't you start out by telling us what a coronavirus is? Just give us the 101 on what we're dealing with. And if a client has a question about the coronavirus, what do you say?
Well, the coronavirus is an RNA virus, and it basically has been around forever. It's not anything new, and it causes something as simple as the common cold. We've dealt with coronavirus for a number of years. There was a serious case back in 2012, a few cases back in the Middle East, and it was very fatal, caused a serious pneumonia. And back then I actually tweeted, I think coronavirus is going to be our next pandemic, and that it's going to cause a black swan. And I was totally right, except, you know, the problem with predictions is you never know when they're going to happen. It took a long time for us to get here. And so the problem with coronavirus, it being an RNA virus, it mutates very rapidly and often. And the thing that made me worry back then is all it needed to do was make one tiny mutation for it to become easy to pass. So very infective. Before, it wasn't easy for humans to transmit it to each other. And what's happened now is it's so easy to pass. So that's in a nutshell what it is. Why is it such a problem now? Is because it's so easy to pass, and we don't really have good treatments for viruses, and we don't have vaccines yet. It's going to take us a while to get through this.
Okay, and it's novel. It's not something we built any resistance to. Mm-hmm. So how is this going to play out over the coming months? I hear people saying that this should be over in a couple of weeks, that we're on the other side of the curve. How is this likely to play out in society?
It really depends. And the reason it's a novel virus is it's a mutation that we haven't seen before, so none of us have immunity. And the problem with RNA viruses, and if you think of influenza, it's very similar in how we build up immunity, is it has a bunch of different antigens that we create antibodies against. And since we have no antibodies, we're not immune to it. Everybody's probably going to get it, be exposed to it at some point. And the problem is because it is so lethal, it's 10 times as lethal as influenza, that our hospital systems, our medical system just can't keep up. And that's why we had to do the physical distancing. I hate the term social distancing because we're all still able to be social here. But that's why physical distancing is so important. It's not going to kill the virus, but it's going to slow down how fast we all get it. The problem, and getting back to your answer here, is how long is it going to take for us to open back up? How long are we going to get through this? The problem is if we start exposing each other again too quickly, we're just going to have another surge in cases. What really needs to happen first is we need to have good, reliable testing, at least antigen testing, and I can explain that in a second, so we know who actually is carrying the virus. And we need to have abundant testing where we can, point a person testing, actually, where you can test at home before we open back up would be the ideal situation. We also need a better understanding of how to treat it. It's very sad. You've heard some people, and there was a person in Texas, a politician, who said, I think we should just, an older person said, I think we should just expose everybody, and I'm willing to sacrifice myself for the economy. And, because mostly, and that's sad, because mostly older people and people with immune disorders are highly likely to die from it, but still regular people without any underlying risk factors that we don't understand yet are dying from it. So why would we do that to ourselves? And so ideally, if we open up too quickly, we're going to see a surge. And then what's going to happen is everybody's going to oh, wait, we got to shut back down. Everybody's going to buy toilet paper again, and we're going to be back to square one. Hopefully we get testing soon so that we can have a more orderly reopening of the economy.
And what does that look like? What does an orderly reopening look like?
Well, I think what's going to happen, and what should happen, is that once we, and I have to reiterate this over and over, once we have good testing, and there's two types of testing available, PCR testing and there's CRISPR testing. And the CRISPR testing, they're really early in getting there, but that's when it basically looks like a pregnancy test. You can test at home and a little stripe comes up that says you're positive. It's not done yet, but ideally it would be cheap, and hopefully we'll get there in a few months. And I'm seriously saying in a few months. And then you provide those tests widely so that people can test themselves at home. And I think we start with the occupations that are most important that we need to get back out there. And then we just start we do it in waves, a few million people at a time, see how we're doing, maybe a new wave a week to make sure that we're not overwhelming the medical system again.
So the best case scenario is a gradual reopening of the economy, more essential services beginning one at a time, making sure that everybody is tested so that we know we're not exposing ourselves or other people to the virus. So it sounds like in terms of economics, by the end of the year, we're not going to just get back to where we were a few months ago, that this is going to take time. And what's the best guess for a vaccine? I know nobody knows, but you mentioned before that an RNA virus is difficult to create a vaccine for.
Well, think of influenza. We have to get influenza shots every year. And why is that? Because the virus mutates very rapidly. And so the influenza vaccine that worked last year may not work this year. And plus, influenza vaccine is only partially effective. You have to guess in advance what the antigens are going to be. And the coronavirus is very similar in that respect. So it's not going to be a one-time vaccine and we're all going to be protected. It's going to be an ongoing program. This is going to bring up a whole different conversation with the people who are anti-vaccine, because it's not going to be like the polio virus or shingles or the pneumonia vaccine. It's not a one-time thing. It's going to be an ongoing program. And then the second thing is we have to develop good antibody testing too. That's the other thing that will help us determine when we can reopen the economy. So once people get antigens, are what the virus produces, and our bodies produce antibodies against those antigens, and that's what helps protect us. And so when we get sick, you can test a person for antibodies to see if they've been exposed to the virus. Right now, the development of those tests is very early because we've all been exposed to other types of coronaviruses. So there's cross-reactivity between the innocuous coronaviruses versus this COVID-19. And so once we have really good antibody testing where we can definitively say this person had COVID-19, then we have to figure out how long does that give them immunity? So for example, you could have had the flu 10 years ago, well, you can get the flu again. And so we just don't know, and that's going to take time to tell. So I really think an antibody program will come out first, antibody testing, because that's much easier to do than to create a vaccine. And a vaccine is probably a year and a half on the horizon.
A year and a half on the horizon. So, I mean, that means that we have to be quite a bit more organized about how we approach this so that we don't end up overwhelming the healthcare system again. And so I think, the best advice that you can give is that this is going to be a long-term effort, that life is going to be different over the course of the next year. The economy is going to look different than it did last year. You mentioned also that most Americans eventually will probably get this. And it does seem like a bit of a crapshoot about who ends up in the hospital, who ends up in long-term care or needing intensive care for a longer period of time. What kind of advice are you giving your clients about being prepared for the cost of healthcare? Now, you yourself, I know you're very careful about making sure that you're not incurring costs. And this is one of the problems with the healthcare system, that if you end up in a situation that's an emergency, sometimes you can expose yourself to risks in terms of cost for healthcare.
Yeah, so I mean, to me, this goes across the board, whether it's coronavirus or anything like that, is that, first off, I hope this is a huge wake-up call for us to fix our healthcare system and how we pay for our healthcare system. So that's number one. Number two is, in general, the healthier people keep themselves, the more likely they're going to be resilient against these sort of things. And ideally, you won't get sick as fast or as severely. And so ideally, you won't end up in the ICU. But either way, the most important part is to make sure you have enough money to meet your deductibles if you have health insurance. And you also need to make certain that you have health insurance that covers all the essential benefits. I know a lot of people in the past few years, because of the cost of health insurance, they've gone to short-term plans, which cover barely nothing. They've gone to the Christian cost-sharing plans, and I'm really concerned about those types of plans being stressed by something like coronavirus, because you have to realize those cost-sharing plans, everybody's pooling their money. Well, if everybody's getting, or a huge percent of these people are getting a serious case of coronavirus, is the cost-sharing plan going to be able to meet their costs? So these are issues. I really think everybody needs to make sure they have good coverage with essential benefits, that they have the savings put aside to meet their deductible year after year. One other complaint I have about people who are investing their health savings accounts, now, people had their health savings accounts in stocks, and if that took a 40% hit, do you still have enough money to cover your health costs? So you've got to think about those things and make sure you have the money set aside.
And one of the big risks is that you might end up out of network.
Yes.
And how can you protect yourself against that?
Yeah, so out-of-network billing is a huge fight. Everybody agrees it's wrong. And what is keeping that from being fixed in Congress is you have two groups at war. You have the insurance companies who want to be able to set the prices for out-of-network billing. And then you have the providers, the hospitals and doctors, who want to be able to negotiate over the prices for out-of-network billing. And for those people who have seen all the ads from the dark money of, warning you about legislation for out-of-network billing, it's a lot of these companies, the venture capital companies, that have purchased physicians groups and one of the ways they're making lots of money is out-of-network billing. So it's a huge political fight right now. And many of us thought that out-of-network billing would be addressed in the CARES Act, and it was not. And so we're hoping in the next package that there will be out-of-network billing issues resolved. But that's, who knows? There was just an announcement from the White House, and this is one of the good announcements I've seen, is that any hospital that has received funds from the CARES Act cannot do any out-of-network billing. So that's a good thing, but that was just a pronouncement from the administration. I don't know whether that will be upheld, but that still doesn't cover the doctors. So if, the hospitals don't employ doctors pretty much anymore, that a lot of hospitals hire independent contractors, so these basically venture capital organizations, to provide the doctors. So they're not covered by that. So what I caution people to do is already know in advance what hospitals you have that are in network, and make certain that your doctor knows you want to stay in network. If you end up going to the hospital, make signs in advance. You and I talked about it, and people laugh at me, but you have to do everything you can and say, make sure everything you provide to me is in network, whether it's laboratory people, pathologists, anesthesiologists, radiologists. Keep me in network. And everything you sign, you say, am I giving away my right? Am I giving you the right to hire out-of-network people, and then refuse to sign it? And if they refuse to treat you, they can get in trouble. So just stand up for your rights. If you're really sick, make certain you have an advocate there standing up for you.
Okay. And if you have Medicare, what do you need to consider?
Well, if you have traditional Medicare, it's not as much of an issue. You have Medicare with your Medigap plans, But if you have Medicare Advantage, that's where it can be a huge issue, because Medicare Advantage can have very narrow networks, and so you can be hit with out-of-network billing too. One thing I forgot to mention on out-of-network billing is many states do have protections against out-of-network billing, so make certain you know the rules. Even in states where there are protections, organizations will try to bill you out of network still, and it's illegal. So make certain you know your rights, and if you're being billed out of network in a state where you know that it is not allowed, make certain you complain to your state health insurance regulators.
Okay, so Medicare Advantage, the problem is that you may end up out of network. And traditional Medicare, you got to pay attention to whether or not you have Medigap.
Oh, yeah, everybody. And, it's amazing to me, 90% of people have Medigap policies or Medicare Advantage. So there's still 10% of people floating out there that do not have Medigap policies. And what that means is Medicare only pays 80% of the cost. So there is unlimited cost sharing for people who do not have Medigap plans. If you don't, you have to get a Medigap plan when you first get on Medicare. And if you haven't done that, you have to pay a penalty for not doing it. But still, you need to get a Medigap plan in place as soon as possible if you don't have one.
And let's take a moment and talk about expenses for healthcare in retirement. We know that medical expenses tend to go up as you get older. I know David has done quite a bit of research on expenses in retirement. And David, what do you find about how much we end up spending in retirement, especially as we get older?
Well, so most people as they age, there's this fun analogy, the go-go years, the slow-go years, the no-go years, where your spending tends to decrease in real dollars as you move through retirement. But you have these things, healthcare shocks, right? So the longer that you live, the higher the probability of having a healthcare event that could be very expensive. But for most people, they don't actually increase their consumption every year by inflation.
So in terms of healthcare expenditure, as we get older, we're spending more on healthcare, but we're not doing as much. So we're spending less on other things. I guess that's one of the things that makes this an unusual event for retirees, and it ends up having a lot of serious consequences. Carolyn, can you talk about the vulnerability in particular of older Americans so far, what we've seen from the numbers?
As far as in regard to the virus or the cost?
Well, the virus and the cost. In terms of the percentage that will end up in some sort of more expensive extended care.
Yeah, so one of the problems we're seeing with the outfall of coronavirus is not just it makes you sick, and as you're older, you're more likely to end up on a ventilator. The current death rate, if you end up on a ventilator, is right now somewhere between 50 and 80%. So it is not very good if you end up on a ventilator. And also the amount of time you have to stay on a ventilator usually is a few weeks. And what ends up happening then is you lose the ability to walk, take care of yourself. So most of those people do need extended care. Medicare pays for part of the first 100 days of skilled nursing care. So that's a good thing. Ideally, if an older person is fairly healthy, they shouldn't use more than that. But if they were already marginally healthy, coronavirus is yet another one of those illnesses. It's just like pneumonia or a hip fracture. There's usually some seminal event that'll send somebody into what we call in the medical community the dwindles, where they just start losing the ability to take care of themselves, and they get problem after problem. And that's when they start needing more long-term care, either home health care, or they need to move into assisted living or skilled care. So a bout with coronavirus may be the seminal event that causes a huge long-term care need for those people.
And I guess one of the benefits of physical distancing is that it does give us time to improve medical care. That we'll understand the virus a little bit better, we'll understand treatments a little bit better. We won't end up with many of the serious consequences that we're seeing for older patients.
Right. That's why we're doing it. We're buying time. And it's so important for us to stop and realize that there are so many people out there saying we just need to get this over with. And I saw a comment that, the number of people that are going to be hurt economically and commit suicide from the shutdown and all of that. We don't know. This is yet another example of complex adaptive systems, which is my favorite area of study. You don't know what's going to happen. So you have to go with the most likely route of what should happen. And so the nice thing about physical distancing is right now we are working on antibody testing. We are working on more widely available antigen testing where the doctors are doing controlled studies on treatments. I was so mad when the president started touting hydroxychloroquine. And there are no studies on that. And now the first study has come out and shows, well, yeah, who knows whether it's improving the disease, but it's causing people to have heart arrhythmias and dying from heart problems. So we need to have real science here, and it takes time to have good science. So physical distancing will allow us to do the studies that are needed. And thank goodness, the one thing I love about my medical community is, the system stinks, but when push comes to shove, they're going to rise up to the occasion. And the researchers are out there working overtime. All the doctors are working overtime. This is what they were born to do. And so I think we'll have a lot of good answers in the next 3 to 4 months. And then again, we can start stepped opening of the economy. And one thing I failed to mention, a lot of smaller areas, rural areas, smaller cities are probably in better positions to be able to open up a little bit more quickly. And so there are different ways we can approach this. I think that will make sense that we won't have to do what we're doing right now.
Yeah, especially geographically isolated cities like Lubbock, Texas, for example, if there's testing, then we can be sure that we're not spreading the virus. That would be a great opportunity to begin opening up parts of the economy. What are you telling your clients right now? I mean, given the fact that so many of us will eventually be exposed to the virus, what can we do financially to prepare for the possibility that we might get it?
So I just wrote an article for CNBC about a little bit about this, and it just came out today. And the key, this is what I have preached for the last 10 years. So I have to tell you, I'm a little sad and bothered that the things many of us have talked about are finally getting attention, which people should always be prepared for untoward events. Coronavirus is a big event, but on a day-to-day basis, you're more likely to get things like cancer, car wrecks, bad things happening in your life. So we should always be prepared financially for bad events. People should have an emergency fund. We should have, I think, early retirees and people who are retiring soon. I think they are way too aggressively invested in general, and they get caught up in the frenzy of the stock market. So they want to make more money, but then, this catches them by surprise. Hello, most of us have been, I know I'm 55 and I've been through 3 major market upheavals in my since I paid attention to the market. Poop happens, right? And in people who are too aggressively invested when they're living on their money, this is just wrong. So in our practice, we always make certain people have at least 10 years worth of cash flows invested very conservatively. So things like that, making certain that your wills are up to date, that you have power of attorney documents, that everything's structured right, that you're insured for both your disability and life insurance. All the basics of financial planning we've been screaming about. It's important that people get that done.
Carolyn, someone asked, and you hear this question a lot, is it worth shutting down the economy for 3 to 4 months as a policy approach to dealing with this? Is it really that simple of a question?
See, the thing is, you don't know the right answer. From a standpoint of a medical standpoint of do we want to save lives? Absolutely. Because if we open the economy too quickly, number one, we don't have enough medical supplies, which that brings up the point of looking at our supply chains going forward. We don't have enough medical supplies. And also we have medical, all our physicians and nurses, we're losing them. They're dying. They're getting sick too. And so just opening it up too soon is just going to cause a poop storm that's going to make it much worse than it needs to be. And so that is why, I think right now we're starting to see a leveling off of cases because we've done a good job with physical distancing. Now's the time to start talking about how to open it back up and then, do it a little time, see how the medical community is dealing with it and go from there.
Yeah, I think historically, when the response has been, and there are countries right now like Sweden that are taking a slightly different tact. And I don't know if you saw, there was a great speech by Angela Merkel about how many other people you infect and the impact that ultimately has on how quickly this spreads throughout the population. And really, if you can just manage how many people everyone infects who gets the disease, then you can flatten that curve over time and have some sort of a manageable response. And so the question becomes, what is a manageable response, and can we actually have a economic recovery if everybody simply goes back to work tomorrow?
So to me, a manageable response again is the rate. What's the rate limiting factor of our health system? And the sad thing about the health system in the United States is that we've been fragmented and very inefficient for a very long time. Germany and the other European countries have a great primary care and community health care system. So they're much in a better position to be able to handle this. And so, yes, we should be very thoughtful about how we expose ourselves. I don't think we should go back to having football, stadiums filled with, tens of thousands of people. I think we need to keep groups small still, and we don't need to open up big businesses where you can still continue to work from home. But smaller groups of people, I think, would probably be the first step.
So it's really about managing a new normal for a while and getting used to a society where physical distancing is more commonplace than it was.
Yes.
But that's going to mean some economic hardship for some people. And as you said before, that's why we save money for a rainy day, because you have rainy days, and a portion of society is experiencing that right now. This is really an approach, Carolyn, that you have espoused for a long time. And I think a lot of other financial advisors have taken what I think Wade Pfau calls the safety first approach to planning, especially planning for retirement. Explain to us what that safety first approach is all about.
So it's very important for people to understand how much they need. I think a lot of people, they go into retirement with, oh, I have this pot of money, how much can I spend? And that's the wrong approach. You need to start, how much do I need to spend, and make sure you have enough money for that before you retire. So that's step one. And then two, we break it down into what are the needs and what are the wants. What if everything fell apart, what could you get away with getting rid of? And for most people, they have to keep a roof over their head, food in their belly, and pay for their health insurance and their transportation. So what's the cost of that? And that definitely you should have, for us, we make certain people have 10 years worth of cash flow to account for those needs. I mean, the needs. And I think portfolios need to be conservatively constructed. So most of our retirees, unless they have too much money, you have people who have more money than they're spending, and they can choose to take more risk. But for those who have enough, we don't let them take more risk than they can financially or psychologically afford. So most of our portfolios for early retirees, it's the equity glide path. We start with anywhere from 50% to 70% bonds. And people just like, you're not going to beat inflation. Well, we're sure as heck beating inflation now, because people who were 70% equities, they just lost every bit of inflation they gained in the past few years. So that's our approach to that. Other opportunities, I'm a fan of immediate fixed annuities at the right point. You know, when interest rates are rock bottom, it's not easy to buy those. And so if we can manage cash flows without worry, you know, by using conservative investments, we're not going to do that. But as people reach their 70s and 80s and it looks like they're going to have longevity, that's when we look at immediate fixed annuities. And of course, making certain people maximize Social Security. So giving them that nice and minimizing bad debt. There is no reason to have a ton of debt in retirement, or any debt for that matter.
Right. And David, your approach is similar. You've studied also the value of things like mortality credits in retirement. Why would a retiree choose a mortality credit as opposed to something like an equity risk premium?
Well, I mean, interesting, you know, like I think along mortality credits today, they're increasingly valuable, right? So the most valuable investment you can actually buy right now is probably Social Security, right? As interest rates go down, the value of any kind of product or, you know, investment, for lack of a better term, that pays you based upon how long you live is very valuable. And this actually, you know, I had a question for Carolyn about this. I mean, like, you know, how do you see this affecting the insurance markets? I mean, long-term care, life insurance, even annuities. I mean, this is a really interesting, you know, impact for older Americans. Will long-term care cost more? Will annuities pay out more? Like, what do you see happening next year?
Well, I'm going to be very painfully blunt here, is that we're going to lose a significant number of our older people. And so for the long-term care industry, that is actually a good thing. That sounds so harsh, but you know, the number of older people have gone down significantly. So that's going to reduce the overall long-term care costs for the industry. Will it affect pricing of long-term care products going forward? I don't think so, because this is, to me, a one-time blip on the radar. Once we have this under control, once we have vaccines, once we start controlling the spread of this disease, it's going to be much better, because most of the people that are going to get and survive and do okay with coronavirus, the old people still do okay too. It doesn't mean that they're going to be in long-term care forever. There's just going to be a more short long-term care need. As far as life insurance, I don't see this, you know, once you've had coronavirus, I do not see this affecting life insurance at all, as your ability to get life insurance, because you know, it's just like any other infectious disease that you could catch. You're not at more risk from catching it again. Will it affect life insurance pricing? Again, I think it's a blip on the radar. Once we get through this, the insurers will understand how to mitigate those risks. In fact, I saw Mass Mutual is offering free life insurance, up to $25,000 for all healthcare professionals working with coronavirus patients, just as a good thing to do. I'm not pushing Mass Mutual. I just saw that on this morning, an announcement from them. I thought that was very interesting.
I think it's worth pointing out that for life insurance companies, the unexpected death of someone who is in their 80s is not going to affect their bottom line as much as like the 1918 flu pandemic, when so many people in their 30s died. They were paying a lot less for coverage, and insurance companies were not expecting that higher rate of mortality among that group. It will be interesting, though, to see, you know, ultimately where rates of mortality end up for older Americans and the impact that actually might have on insurance products. But Carolyn, you've always been a big fan of insurance products. You're one of those financial advisors that believes strongly in the importance of risk management.
Oh, absolutely. And you know, for me, the type of insurance product you buy, so life insurance, you know, term is fine for most people, but every now and then, especially with people living longer and working longer, you do need permanent products. With long-term care insurance, disability insurance above and beyond. Everybody who works should have disability insurance if they can get it. As far as long-term care insurance, I am still not a fan of the traditional products. It's to me, the insurers cannot predict the future of what long-term care is going to look like. For one thing we haven't talked about is I do think we are going to see a change in how long-term care is delivered. One of the big outfalls of this is when you put together a bunch of older people who have decreased immune systems, you get a serious case of people dying on your hands. And I've never been a fan of warehousing older people. I think we need to come up with more innovative multi-age communities to help take care of our older people so they're not all together and getting sick at the same time. And I think if we change how we approach long-term care, helping people plan better for the logistics, that we can reduce the cost of long-term care and better plan for it that way.
What kind of advice do you give your clients about long-term care insurance?
About insurance. Okay, well, first off, we do a long-term care plan to figure out how much are they potentially going to need. I mean, everybody has a different idea about what their aging looks like. Almost everybody says, I want to live in my home no matter what. And when you you have to look at their health. If they're very healthy, it means they have a higher chance of getting dementia and needing round-the-clock care just because of cognitive issues. So when you explain to them, round-the-clock care is 3 times as much as going into a facility. So if you tell your children, I don't ever want to go to a nursing home, you're hamstringing them with a huge potential long-term care bill. So you put that long-term care plan in place in advance where they agree at certain points they'll go towards skilled care when it's going to be more expensive to stay home. So you plan out the logistics of where they're going to live, when they're going to give up driving, which is actually a long-term care issue people don't talk about. Have they done advanced directives? Too many people don't talk about end of life with their families. And so families end up spending a lot of money doing care that is not wanted by the patient, the elder person, and that would probably be unnecessary care that ends up being expensive. And then when are they going to turn over financial decision making? Because a senior's greatest risk to their financial security is themselves, because they're more at risk of fraud and abuse and financial mismanagement. So that's number one, is putting that long-term care plan in place. Then you price how much is it going to cost, and how much can they self-insure, and then you can decide at that point, what products do we want to use? We tend to have more success with clients using hybrid policies. A lot of them have old life policies that they don't need. So it's easy to do an exchange into a hybrid policy that's going to give them a bucket of money for long-term care.
Okay. And are you a fan of those hybrid policies?
Well, from a financial standpoint, they're not great. To me, they're just like a bond. They're like a savings account. If you happen to use them for long-term care in the short run, they're going to be a really good deal. If you're going to use it for long-term care in the long run, they might not as be. I feel a lot more secure with those type policies than I actually do with traditional long-term care. I have not been a fan of how insurers are trying to limit how people claim the benefits of traditional policies. So, and when you're old and you're having a hard time getting along, and just how, to turn in all your claims and all that is just a pain. So the nice thing about the hybrid policies, more of them are indemnity type. Once you meet the 2 ADLs or have cognitive decline, you get that monthly benefit without having to turn in everything and being denied care.
Now, you mentioned advanced directives. Specifically when it comes to the coronavirus, is there some sort of guidance that you should be giving your clients right now, given what we've seen in terms of the standard care given to people who have the virus and need to get on a ventilator?
Right. So to me, first off, you always have to talk about what is important to you about quality of life. With coronavirus, that ideally is a short-term illness that you're going to recover from. And most people, unless you end up on a ventilator, most people are going to recover. And so this applies just like any other illness. If you have a short-term thing, then you should be put on a ventilator if it looks like you're going to recover. But if you already have a serious chronic illness, and so for example, I have a client who has ALS, and so Lou Gehrig's disease. He's in the advanced stages, and we had a conversation about, what's it look like? And he said, I'm still drinking my wine. If I get coronavirus, it's not a bad way to go. All right. Because what he's looking at going forward with ALS is very, very challenging. And so if you have a serious chronic illness already, it's really important to look at what are your advanced directives. And if you actually end up having to be intubated because of coronavirus and you're already seriously ill, you might want to think twice about that. And that's an important conversation to have with your healthcare providers and your family.
Especially given the recovery rates among less healthy people who get coronavirus who end up intubated, it
Correct.
might be something we're thinking about. A lot of depressing topics here, and I don't know how exactly to liven things up. You probably, I'm guessing since you are a doctor, you probably have a lot of clients who are doctors right now. What kind of advice are you giving them? I mean, because they are putting their lives in danger as part of their occupation in a way that they didn't have to before the virus.
Well, there's two sets of doctors right now. There are the doctors on the front line that have to take care of coronavirus patients. So that's basically the emergency physicians, the primary care doctors, the intensive care doctors. So yes, and in fact, my physicians who are on the front line of fighting this, they are all gung-ho about fighting this. They're signing up to go to New York because it's not exciting enough down here, not in Florida. They want to go help where help is needed, and I just love that about them. But we make sure, of course, they're all well insured and they have emergency funds. So if something serious, and they approach this with a sense of the respect that it's due. They know that something bad can happen. And when you're in medicine, you kind of know that anyway. The other set of physicians are actually all the specialists, like the ophthalmologists, the orthopedists. Their business is dead right now. Nobody wants to go to the doctor, which really people shouldn't be unless they have serious illnesses. So many of them are having to apply for the assistance loans to keep their practices, all their employees employed, because there's not enough work to do. So that's the two sets going on right now.
That's a big dichotomy. One has plenty of money and lots of risk. And tell me a little bit about your conversation with clients about disability insurance.
Oh, goodness. Disability insurance is by far, in a way, the thing that we make sure people are well, and especially our physicians and high earning clients, that they need disability insurance. So it's not actually an option for them unless they have enough money saved up to not have to worry about disability. So we revisit people's insurance needs every year. We do an insurance review every year. I'm fee only. We do not sell insurance. We are our clients' advocates when they need insurance, so we help them shop for it. So we will help them decide if they're overinsured. And so when you have clients reach in their late 50s, early 60s, some of them don't even need their disability policies anymore because they've saved enough money. So we look at it both ways. And it depends on how much they're spending, how much debt they have. But we're debt adverse. So once they're out of debt and they have a significant amount of savings, we revisit the equation there.
So I think that's very interesting, Carolyn, that you will not advise a client if they don't have disability insurance, and you are not compensated at all for selling disability insurance.
Oh, exactly.
It's just part of your philosophy.
Yeah, we advise all our clients on their insurance products and help make sure that they're well insured. And the nice thing about that is when I tell a client they need insurance, there's no argument because they know I get nothing out of that. They know it's all from their best interest that I'm telling them that.
Carolyn, you recently wrote, speaking of fees, you recently wrote an article about the risk to financial advisors of having an asset-based fee model, especially in a period like the one we've just seen. I mean, of course, a lot of advisors have a lot of fixed expenses. A lot of those expenses are based on a regular stream of income, but their stream of income is really dependent on the performance of the market as well.
Yeah, and I think that's a mistake. To me, and this has come to bear, so I've been on flat fee model since 2007. So I did this before the 2008-9 debacle, and it's the best thing I ever did. We based our fees based on complexity, so how much work we're doing for a client. And then, and so that takes away a lot of the incentives. To me, there's always conflicts with every model, but it reduces the conflicts to me. And so the nice thing about that is when everything falls apart, our cash flow in business is just fine. When everything's going up like crazy, our cash flow stays the same, but that it's not in regards to me. You know, it doesn't matter to me because my job is to do the best thing for the client. Now, the nice thing about it is when you're flat fee, clients don't question your motives around the investments. It does allow me to have good conversations about why they should be in a conservative portfolio, because it's in their best interest. If I'm trying to make them be aggressive because I believe in the market and I'm AUM based, that's to me a conflict there. But it's been very nice for me to be flat fee, and there's been a lot of interest through the years. And in that article I wrote, back when I started, there were just a handful of us doing it. In the last 10 years, it's a bucket full. And are people who are AUM now going to see the light as far as providing at least starting to charge planning fees? I think the most important work we do is financial planning. Investment management is just a small part. It's become commoditized, and people can go out and get that for nothing now.
And how are your clients feeling right now? You've taken a safety first approach to planning. How are they feeling?
They're great. It's like, people say, "Oh, is your phone ringing off the hook?" No. We're very proactive about communication. And so when everything started happening, we just sent out, newsletters of reminding clients that you're positioned appropriately to your ability to take risks. So for all our people in retirement, you have at least 5 to 10 years worth of cash flows and that whole thing. And our biggest response is most people were checking on us to make sure we were okay. Just because, and then the other thing we've been spending a lot of time doing is helping our small business owners. We do have a number of small business owners, so helping them with the loans and all the options there. So we've been very busy. None of our clients have been worried at all. We aren't taking new clients. We've been closed to new clients for since the beginning of last year. And, but Lord knows we have gotten a ton of calls asking if we would take new clients, but unfortunately we're just not doing that right now.
Wow. So Carolyn, at the end of this session, I know you're very passionate about healthcare policy. You have a big audience. What can we do as financial advisors to help move healthcare policy towards a more efficient and better direction? And I think that's something you've been emphasizing for a long time, that the system that we have right now is not just broken, it's less efficient than it could be.
Yep. And so a lot of financial advisors feel like they should not be political. And you can avoid being political, but you can be policy oriented. And so I think we all need to be advocating for good policy for our clients, whether that's a good, whether it's Republican or Democrat, whatever is good policy is what we need to advocate for. And our healthcare system has been broken for a long time. And the reason why that is our country is half individualist and half collectivist. And what that means is half the population feels like everybody should pull themselves up by the bootstraps and figure out their healthcare for themselves. The other half realizes that if everybody had at least a base of care, that we would be a better society. So there's differences in how we approach healthcare as individuals. And this country, the big mistake we've made is we have not decided what we want healthcare to be. Should everybody have healthcare? Who should pay for it? And the other big problem we have is we have no good primary care system in this country. Our healthcare costs are 3 times other developed nations on average. They have way better health outcomes. They've withstood this coronavirus thing way better because they have good community health and good public health. Our community health system has been starved for funds for a very long time. The Affordable Care Act, and I say good and bad things about the Affordable Care Act. The good thing about the Affordable Care Act, or one of the many good things, is that it had copious funding for public health which would have prevented this coronavirus pandemic. It would have had us prepared for it, and for good community health. And when the Republicans won the House back in 2010, the first thing that the House cut in the budget was all of the funding for public health and community health. So they have been starved for funding for the last decade. And currently, the CARES Act gave community health and public health emergency funding, but gave them no ongoing funding. Public health got basically a $2 billion budget in general. That's what it's gotten in the past. Whereas our anti-terrorist event have been, I think that's at 180 billion is the funding we give for that. We lost over 3,000 people to 9/11, and how many tens of thousands of people have we lost to epidemics such as coronavirus and Ebola? Thank God we were able to contain that. But there are about 1,000 viruses out there we need to worry about. It's just not coronavirus. So we need to have good funding for public health, and I think advisors need to advocate for consistent, good funding for public health, primary care, and community health.
Yeah, I think one of the main points that you've made is we pay a lot of money for public health care anyway. We probably, as much as any other country in the world, if we're going to do it, we might as well do it efficiently. And efficiently means that instead of people going into very expensive, publicly funded hospitalization, that having some sort of more primary care that's offered to them is going to be a lot less expensive in the long run.
Right.
Carolyn, any other points that you want to make before we sign off?
The big thing, I was just looking through a lot of the questions here, and I think that there's, gosh, the questions were all over the map, and the one thing I see is that it was questions on cash flow and Social Security, and are we going to have enough money to pay for all these things that we've paid for? To me, one of the things that has come from this is people have worried about the budget, the federal budget forever, right? And you hear this, we can't run these deficits forever, our kids are going to have to pay them back. And the thing that people don't realize is the government is not a household. You don't ever have to really pay the money back. The thing that constrains our budget is inflation. And this QE1 and QE2 back in 2008 and 9 proved that you could put a bunch of money in the system, and as long as you have the goods for that money to buy, it doesn't increase inflation. So all the money that's being pumped in the system now, as long as we have the goods to buy, it's not going to increase inflation. So I think we need to change policy to go more around what's full employment, what's going to control inflation, and quit worrying about the deficit number in and of itself, and worry more about what's good for our country and how we're using our money.
Well, Carolyn, if we ever had an opportunity to put that to the test, we're going to see that, I think, over the next couple of years.
I agree. And
2020, we're already looking at a budget deficit that's equal to the GDP. So it'll be interesting to see.
I think
all right.
Read Stephanie Kelton's book coming out. It's called The Deficit Myth. I got a reviewer's copy, and it does a fantastic explanation of how we need to think about the deficit.
All right. Thank you for that, Carolyn. Thank you so much for spending the time with us today. This is the first part of a 4-part webcast series that's going to be tackling COVID-19's impact from all angles. 2 weeks from today, join David Blanchett and I and Morningstar columnist Christine Benz and financial speaking coach Deidre Van Nest to discuss how you should communicate with clients during this public crisis. Thank you, Carolyn. Be safe and well, and continue to be the pillars of guidance for your clients and your communities. We'll talk again on April 30th. Thanks again, everyone.